Welcome to another episode of the Melbourne Athletic Development Podcast. This episode of Lateral Think is brought to you with the support of Strength by Numbers. Strength by Numbers have created an integrated clinical and sports performance system. The AXIT system uses force platforms, dynamometry, and strain gauges to objectively measure everything from isolated movements to sports performance tasks. The system has greatly enhanced our clinical practice, decision-making, and objectivity. We are no longer guessing. The greatest thing is its ease of use, both for practitioners and clients. There are no wires, no fixed setup. It's a fully integrated Bluetooth system. If this sounds like something that would enhance your practice, visit strengthbynumbers.com and tell them that Melbourne Athletic Development sent you. Jack.
John.
We wanted to talk about manual therapy.
Yes.
It's an area of physiotherapy particularly that seemingly has become controversial, which I don't really understand.
Don't you?
Well, no, not really. It seems a bit ridiculous to me that the foundation of physical therapy for a long time has been manual therapy. And now that as knowledge of exercise has continued to grow, we are using more exercise interventions in what we do.
Yeah, which is a good thing.
It's a great thing. You know, the evidence is supporting that. But we're throwing the manual therapy side of things basically in the garbage. And I think it's actually destroying our profession to give up something like that, given that there clearly is a significant amount of clinical experience and evidence from clinical practice that it's effective. Patients like it, and they find it effective. Yet you talk particularly to younger clinicians, and one of the first things that they try to dispel is the need to use manual therapy. And clearly we think they're idiots, right? And there's multiple reasons for that. And I think it's important that we kind of discuss some of those because there is actually really good understanding of what's happening when we do manual therapy and the effect that it has across multiple systems of the body.
Yeah, and I think a good question to ask to begin with is, where is this message coming from in the first place? Because it's not coming across unanimously from all expert figures or reputable individuals within our profession. It's coming from certain groups. And I see it coming from two particular groups. People who are purely researchers or people who have too much time and want to get into wars on social media.
Yeah, there's idiots like Adam Meekins who just doesn't fucking shut up about this. Like he thinks that it's his thing to basically say there's no point doing manual therapy, even when people push him back on it, and he basically says he does it. But he just thinks how you do it doesn't really matter and doesn't make that much difference. And then you get really experienced clinicians who have a lot of background in using manual therapy saying, well, I don't understand why you would downplay the actual benefit of specific techniques.
Well, and probably a good question to begin with then for you, someone like yourself, John, do you find manual therapy useful?
Of course.
Yeah.
And I think the biggest thing, we always have this discussion, if anyone ever dispels the utilization of manual therapy as being valuable, they clearly have never worked, say, in sport, and particularly in elite sport. Like, if you get someone come off the ground, off the pitch, and it's it's a final, it's a grand final, whatever it is, and they say, oh, my calf's a bit tight, and you can't do anything at that moment to change their perception of discomfort or tightness or tone or whatever they feel, then you're effectively useless at that point. You're not going to say to them, oh yeah, like during the week we'll start doing some calf, strength work, we'll start doing some exercise interventions.
Yep.
You want to be able to create physical change. Now, there are certain things that they may do themselves. They actually might do a series of different stretches or exercises that may actually make their calf feel better, right? But you also do have the ability to place your hands on someone and create some of that change. And I think that the thing that seems to confuse people is, what effect different manual techniques have. And I thought it was important that we discuss that because I know that you've been sort of looking more and more into the evidence around this.
Well, and look, yeah, that's a better question to phrase is what does manual therapy do and in what context is it going to be useful? Because we need to essentially apply the same principle we use with exercise. When we think about exercise, we think about that there's lots of different types and we can determine when we use different types and how we actually configure different variables in terms of like intensity, duration to elicit a certain effect. We have to be the exact same in terms of how we think about manual therapy and applying it. So I think first thing we need to think about is what what does manual therapy do at a neurophysiological level? And
Well, what does it do at a neurophysiological level?
well,
Because the thing is, people would argue it doesn't really do anything.
yeah, and that's just where you're wrong. But one thing that is clear is if you look at some of the underlying mechanisms, are quite well understood, and we understand that depending on the type of manual therapy you use, and in particular the intensity, you will elicit different effects. So this is where I think sometimes you can become undone, where if you're using manual therapy purely as a modality to induce mechanotransduction, it's not going to create a really large magnitude of force to create specific structural changes to the tissue.
Yeah, and it's not going to be those chronic changes that you would see, say, with the long-term application of exercise.
Absolutely.
You know, and these are some of the things that, you know, you see with the studies that are coming out now, looking at changes in, say, tissue architecture associated with types of contraction, particularly if it's done over a period of time.
Yes.
You're potentially not going to see that with something like manual therapy. However, you may be able to start changing the way in which they can undertake that intervention in the first place. Because the one big thing, and you know, we've been talking about this a little bit in preparation for this, is that manual therapy has a huge effect on pain perception. And there's a number of reasons for that. You know, I think you shared a paper with us just this week with our clinical group around, you know, what actually happens when you start to change some of the underlying tissue structure with some mechanical, you know, compression and force, and what that does to some of the biochemical factors in that local region, and also what that has an effect systemically. Do you want to describe maybe a little bit about that?
Yeah, well, sure. And this is where I reckon it's worth taking a step back and thinking about manual therapy can assist with the process of hormesis. And I think that's a good way to phrase it, because it's something we've talked about before.
We've spoken about it before, but for people who don't know what hormesis is...
Hormesis is the biological response to a stressor, whereby we induce adaptation that can be positive or potentially negative, depending on the type of stress and the magnitude of the stress applied. So essentially this describes the adaptations we see from, say, exercise, and we think about, say, resistance training to induce hypertrophy. That reflects the fact that our system is adaptable, and when we apply mechanical stresses, the body responds by inducing neurological and physiological or peripheral changes to be able to better withstand those stresses in the future. So again, let's put this into context. You've got an athlete, they're training full time. They're applying a lot of physical stresses to their body. And when you apply physical stresses, you're affecting multiple systems. There's the musculoskeletal system itself, where you're going to induce adaptations to the muscular, connective, and bone tissue as it adapts to that particular stressor. But we're also going to be regulating other systems. So the thing that will intimately influence the response of the musculoskeletal system is the immune system. This is something we've talked about before, but we have to appreciate and understand that the immune system, and specifically the inflammatory response, is intimately related to the adaptations that occur to the musculoskeletal system.
Well, I think that's something that people don't seem to really know that much about. You know, like I think that we see that these systems are separate, that the immune system is not going to be heavily affected by, say, undertaking exercise or something like physical touch or the inflammatory status of the individual based on their diet. But it's really clear that these factors interact a lot when it comes to overall health, but also particularly in our realm of like the actual physical and musculoskeletal health.
Yeah, exactly. And it will determine the type of adaptation that occurs too. So this is something that's very well established in the literature. When you look at, if you think about muscle adaptation in terms of satellite cell activation, proliferation, differentiation into myotubes, myoblasts, and so on, that is all determined by the chemical environment, and specifically cytokines. So when you think about things like macrophages and interleukins and other cytokines or chemokines, the amount and the ratios within the environment will determine the process of satellite cells being activated and eventually turning into muscle or connective tissue or extra bone.
So basically you're saying like the actual environment that these cells are in will actually heavily influence how much adaptation you get.
Absolutely.
So if you're doing exercise, for instance, and you want to maximize on that, you obviously don't want to be in a negative chemical or biochemical environment for that tissue.
Exactly. And at the same time, you also don't want to be in an excessive inflammatory state. So this is where it's really important to...
Yeah, because I think this is good you brought that up, because, I see this discussion happening a bit where people are like, inflammation's good, inflammation's bad. Do we take anti-inflammatories? Do we not? What do we want to dispel with that? I think it's important to understand, and I think you've discussed this a fair bit with our group, but that inflammation in itself is neither good nor bad. It has to do with how much there is, and it has to do with what it's responding to. Yes,
and the timing, and also the relative ratios of different inflammatory markers. And you can grossly divide them into pro and anti-inflammatory markers. It's definitely an oversimplification, because certain cytokines may be pro or anti-inflammatory based on the environment that they're in. But this is something that's so tightly regulated, and is something that occurs in response to any type of stressor, whether it's a mechanical or a non-mechanical stressor. So again, when we do exercise, we're applying a mechanical stress, we're inducing an inflammatory response, and that helps regulate the adaptation of tissue. Now, one of the issues that we're constantly doing, as physios in a rehab setting or for yourself in high performance, is trying to manage the magnitude of stresses to make sure that they're getting adequate recovery and that they're not applying excessive stress that eventually leads to overtraining.
Yeah.
And this is where we go back to thinking of, well, where does manual therapy actually fit in here? And it goes back to the paper that you were mentioning before, because we also know that...
And this comes out of Paul Hodges' lab, doesn't it?
Correct, and it's in collaboration with some of the work that Carla Stecco and the Stecco group have been discussing.
Which university? They're in Italy. What university?
She's at the University of Padova, and her brother Antonio is at the University of New York. So certainly would recommend looking into their research, because all their research is understanding the anatomy, physiology, and the pathophysiology associated with the connective tissue system.
I think it's like the thing that I always find interesting is looking at how researchers evolve in their thinking over time. And I think Paul Hodges is very well known in Australia,
of course,
particularly in the physiotherapy world, and a lot of his research, I think, interestingly, has changed so much. One of the key things that I think is really different is he's kind of gone back on a lot of the work that he did.
Yeah, massively.
He spoke a lot about these inhibitory kind of behaviors of tissues like multifidus and TA and what that meant for the experience of back pain. He seems to have kind of evolved his thinking into a much more complex arena.
Well, I think the issue too with some of that early research from Paul Hodges and Gwen Jal is understanding what that actually means. Because it's not to suggest that you don't get, say, inhibition of certain musculature with long-term pain. I think that's definitely the case. It's understanding, why are you actually seeing that inhibition? Because I think we've talked about this before, where if you get an injury and a muscle just quote unquote switches off, from an evolutionary perspective, we wouldn't have survived for very long, because there's no ability for you to survive in the natural environment where you would have probably got injured quite frequently if all of a sudden your glutes or your multifidus or your TA just switched off and never came back.
Well, I think that brings to an area that needs to be addressed, which is this idea of activation. And I think we've spoken about this. We spoke about this when we spoke to Tanya. This concept that something doesn't activate is a crock of shit.
The term itself is actually incorrect. What they're referring to is excitation.
Yes.
And because what we're not measuring the contraction of the muscle, we're measuring the electrical activity that occurs. And yes, those two things are correlated, but they're not. It's not a one-for-one match, because when you think about, a simple way to look at it is if you think about the magnitude of a force from a muscle, one obviously is related to the neural drive. So when you think about the amplitude and the frequency of the neural signal being sent from the brain down the spinal cord to recruit motor units. But it's not the only thing, because the other big things are the length of the muscle, the cross-sectional area of the muscle, the associated connective tissue that will determine how much force can be transmitted effectively to the joint, and also the velocity of the muscle itself.
And I think these factors are the things that are not being discussed when people talk about this idea of whether something is activating, right? And I hate that term because to me, as you said, it's not actually talking about what it should be, which is excitation. But the other big factor that I think is really relevant with it is a lot of it's built around this concept of what people perceive. And we've spoken about this idea of interoception. Often when someone has an injury or they have a period of inactivity, that interoception goes down. And you've actually, it's in this paper, we'll get back to that paper in a moment. We're kind of getting a little bit on a tangent, but let's finish this because you know that activation is something that we get real pissed off about.
Absolutely.
Or at least the concept of how people use the term. The thing that is interesting about it is because the interoception goes down, people have this concept in their mind that, oh, this isn't turning on. And that's not what's happening, right? If it wasn't turning on, you would have a significant amount of, inability to carry out the task. You wouldn't be able to move a joint. You wouldn't be able to carry out the motor patterning that you would need to actually do whatever you're doing.
Yes.
So you're saying, oh, like my glute's not activating. You would be very aware. If anyone's ever worked with a neurological patient, that's true inactivity. That's true muscle, excitation not occurring.
When you've got some type of upper or lower motor neuron lesion.
Yeah.
If you're talking about
and when that occurs, you clearly can see that there is not activation of that tissue.
Yeah, absolutely.
But if you haven't had one of those things or you don't have some sort of lesion, as you said, whether it's happening at the lower or upper motor neuron level, there is no way that you're not getting activity happening within that actual tissue.
Yeah, and this so let's bring it back to the paper recently shared that was published from Paul Hodges' group, is thinking if there is a change in sensory motor output, which definitely occurs, that's not the question. We've got to be thinking, well, why is that the case? Because usually the biggest one is just because of a lack of physical activity leading to atrophy of the muscle. And that's a big problem, and I'm sure a lot of people can relate to this, of people who experience pain, particularly back or neck pain, because there's negative connotations associated with it. They go through a period of inactivity, which leads to maladaptations, both centrally and peripherally. And this is from this paper, what they were looking at is what happens to the muscle spindles within multifidus in response to an intervertebral disc lesion. And what you see is changes within the amount of collagen and connective tissue laid down around the muscle, but specifically around the edges of the peri and epimysium where the muscle spindles are located.
And I think that's the most interesting thing is you get this specific change happening at the muscle or at the side of the muscle spindle.
Yes.
And of course, you're going to get changed interoception because the muscle spindle is the actual sensory organ or the sensory feature that is trying to measure what's going on within that tissue. And if you're not getting that feedback to your central systems, of course you're going to say, well, I don't feel this. I don't get that same sense of tension or tone or feeling that I would normally get because you've actually had a change to the structure of that muscle spindle connective tissue, lay down.
Exactly. Well, they're intimately involved in proprioception, but they're also intimately involved in muscle recruitment.
Yeah.
Because something that a lot of people forget when you think about the stretch response is when you try to recruit a muscle, the first thing that your muscle will do is it will create a gamma efferent to contract the intrafusal fibers that go through the muscle spindle. And the reason why it does this is it's monitoring tension or length and also the rate of length change. And this makes a lot of sense too because this is a protective mechanism. So, for instance, if you're someone who's sedentary and you haven't done any physical activity and you go out for a sprint going maximum velocity, because you're unaccustomed to that degree of tension and the rate of tension, you're going to have a limitation for your ability to recruit your whole muscle during that activity. As opposed to, say, an elite sprinter with multiple years of training, they're going to be able to utilize their muscle tendon unit during those high velocity contractions because you've familiarized yourself with that particular task and you've obviously built up the structure to be able to tolerate those forces.
And that to me reminds me so much of the discussion we had about flexibility. It was one of the early podcasts that we did, and I think it's really important to highlight this is, one of the key things, as you suggest, changes is the inhibition that occurs with your stretch tolerance. And I think that a similar thing happens when you haven't been accustomed to an activity, as you're suggesting. You don't have that same feedback, and therefore your system is saying, okay, I'm not sure whether this is a smart thing for me to be doing.
Yep.
Right. So it actually, as you said, it will down-regulate how much recruitment you'll get.
Well, exactly. If your muscle spindle is compromised or it's starting to experience a lot more tension because you've got this lay down of disorganized connective tissue around the muscle spindle, it's going to send an afferent signal that will limit your ability to recruit your alpha motor neuron, which is the thing that innervates the extrafusal muscle, i.e. the whole muscle itself. So this is quite an important finding because it's showing that in response to injury, if you don't apply appropriate stresses early on, because this is looking at changes 6 months down the track, you're going to see changes within the peripheral environment that influences your sensory motor output. So when you think about the clinical significance, this highlights a couple of things, that if you try and reduce quote-unquote motor control just down to using certain internal cues to recruit a muscle, it's still going to have limited capacity to contract that muscle because of the peripheral changes. It also highlights the importance, or the likely importance, of doing physical activity early on, because some of Paul Hodge's previous work of looking at fibrotic infiltration following injury, that's limited when you do general physical activity by applying mechanical stresses through the tissue. And again, that's because of the regulation of the inflammatory environment that occurs in response to injury. The next thing we need to think about then is, well, where does manual therapy fit into this?
Yeah, well, that was what I was going to come back to, because we're talking about these changes occur, but what actually are we going to get out of applying, say, some sort of manual therapy stimulus?
Yeah. So if we even look at the most common type of manual therapy we use, of, to say, soft tissue work, where you're doing more like broad strokes through the tissue environment, you have a large impact on the inflammatory state of that local environment. And that makes a lot of sense, because think about what happens when you start to apply a gentle manual therapy or compressive force. It causes vasodilation. So, in response to injury, or even just in response to training, you're going to get an increase in tonicity. And that's going to be mainly regulated from an increase in your sympathetic output. So you're going to upregulate the parasympathetic nervous system, which will assist in vasodilation. And that's going to improve perfusion of that associated area and start to clean out some of the metabolic byproducts and inflammation that accumulate from either an injury or in response to a lot of training. And the other thing that it also assists in doing is assisting in pushing fluid through the interstitium and clearing out metabolic byproducts through the lymphatic system as well. And again, that's something that's really important to consider, where particularly for people who are unhealthy, but even for people doing lots of training, if they've got a lot of tonicity, that's going to create more tension through their superficial fascia, which is where the lymphatic system is located. That will determine how well it clears out those metabolic byproducts as well.
Okay, so we're starting to see that the use of manual therapy has some really clear physiological effects. Even really simple things, as you said, like manual therapy that has a massage or type of compressive type forces through local tissue.
Yes.
What about the effect that it has on something like those changes that you're seeing in the muscle spindle?
Yeah. So this is where it starts to get interesting, because again, we could apply just more general types of manual therapy to mitigate the accumulation of inflammatory markers that will cause that fibrotic change, because that's something that's quite clear when you look at fibrosis. Fibrosis occurs in the presence of long-term inflammatory cytokines within that tissue environment. And that's why if you look at people with poor health who have got, say, levels of systemic low-grade inflammation, they start to lay down more fibrotic tissue and become stiffer over time because of the chemical signals telling the tissue to lay down more disorganized collagen.
And interestingly, you kind of feel that. So when you're actually feeling through someone's tissue that's had, say, previous injury, or they've actually done a lot of it, like you said, they've been sedentary, you can actually feel the difference between the quality of their tissue compared to someone who's doing a lot of activity and exercise regularly.
Yeah, actually, we haven't talked about, we need to talk about this, is what information you get from putting your hands on someone.
Well, let's finish off this part about this, because I found this the most interesting about what, we put into that discussion we had after you presented that paper to the group,
Yeah.
which was at that muscle spindle level. I think there was some changes that occurred actually from that intervention that meant that the information coming to and from may actually be altered in a relatively short period of time with the application of manual therapy.
Yeah, well, this is looking at the application of localized friction work.
Yes.
So this, to understand the effect of localized friction work, we need to understand changes that can occur at the connective tissue system. Because at this point, we've talked about fibrotic change, which is something that most of our listeners are familiar with. But that's more of a long-term change. The more short to mid-term change within the connective tissue is not an increase in the laydown of collagen, but changes in the extracellular matrix, specifically with hyaluronan and how much hyaluronan is binding to water. So,
and I think like this is one of the key things that I thought was the most interesting when you started looking at what actually happens between these different layers of tissue is that hyaluronan is really important for particularly the viscoelastic kind of behavior of tissue, the sliding effects between different layers of tissue, and the actual sensory information that people get back when they say this feels tight or this feels like it's not moving, or these kind of descriptions. I think to me at least, and maybe I'm taking too many jumps forward, but I think this is where we're getting the feedback that we get from our patients about like what they're actually feeling is this lack of information, or the lack of information they get back because there's been alterations in this hyaluronan.
Exactly, because if you think about acute changes in stiffness, it's related to two things: autonomic nervous system regulation in terms of parasympathetic to sympathetic outflow, because that's going to determine the tonicity of the muscle, and then also the viscoelastic behavior of the myofascial system. One thing that we need to better understand and appreciate is the multi-layered component of the myofascial system. So if you think about all the interfaces between different muscles, intermuscular septum, or even between the epimysium and the aponeurotic fascia, we have loose connective tissue that allows the independent sliding of these layers. And within this loose connective tissue, you have hyaluronan that's bound to water. In normal physiological circumstances, when it's bound to water, it creates a gel-like substance that's essentially like a lubricant. We can get changes though where instead of the hyaluronan binding to water, it starts binding to itself. So if you look at it under imaging, which they use a MRI, they use a T1 row scan, you can see that there's all this unbound water. And the reason for that is because all the hyaluronan is bound to aggregated to itself, and that changes the constituency of that loose connective tissue where it becomes more viscous.
Do you think that that's what we feel when you touch someone's tissue that feels like it's not moving well, or the tone is very different? Do you think that that's what we're actually starting to feel?
Well, I think we need to look at tone and gliding as different things, because there's certainly times when you feel a muscle and it's just tight.
Yes.
So we're not talking about the tonicity of the muscle. We're thinking about as you try and almost glide over different layers of tissue, it feels stuck, or I often describe it as gristly.
Yes.
That's probably a good way to think of it. And
to me, that gives me that image of potentially, like, is it that hyaluronan being aggregated to itself? It's sort of that gristly kind of feeling.
Yeah, absolutely. And this is something I think we've all felt, but it hasn't been well described until more recently. Again, credit to the Stecco group, because this is where a lot of their research is looking into this. And the good thing about this too, this is something that we can feel, and we know that there's good reliability in what you can feel as well. And so when you think about that continuum, whether it's in the presence of an injury or following some heavy bouts of training, we're going to get some changes in the constituents of the extracellular matrix. Now, depending on the circumstances and depending on what other modalities you're doing, you may mitigate that densification from staying or becoming problematic if you apply the appropriate stresses. So one way that we can get rid of a densification is through applying friction. Because when you apply friction, it will cause the hyaluronan to break down into smaller fragments that then your body clears out, and it will start to secrete fresh hyaluronan that then binds to water. Now, this also explains too that when you do, say, lower intensity manual therapy, or even if you just do a basic warm-up, we start to feel an improvement in our movement or our stiffness, because as you heat up the tissue, it will cause the hyaluronan to not bind to itself and bind back to water. But in the more significant changes, as you cool down, the hyaluronan will just bind back to each other. So when you apply friction, it's going to change the extracellular matrix by causing the accumulation of hyaluronan to break down into smaller fragments that we can clear, so that the ratio between hyaluronan and water is optimal for normal physiological behavior.
Yeah, and I think this observation is the one that everyone is aware of. As you said, like, you start moving, you start stretching, you start warming up, tissue temperature goes up, and all of a sudden you don't feel as stiff, you don't feel as restricted, you don't feel as though your tissue doesn't have the ability to be compliant.
Yes.
And I think this is the same thing that the same feeling particularly that people get when they've had manual therapy. Even if it's a short intervention, as you said, like, people will get up off the table or however it's been applied, and straight away they'll actually say, oh, that actually feels like it's moving better. That feels better. I'm actually getting better feedback from that tissue.
Well, and using this example, I think this highlights too where we need to differentiate manual therapy based on type and intensity and so on, because if we just do more general low intensity manual therapy, which I use a lot, particularly say in the context of, say, a rehab session, someone comes in, restricted movement, do some manual therapy to create a window for them to be able to apply load through a larger range of movement. But that the effect of that manual therapy may only be short-lived, as opposed to if we start to do more concentrated friction at a higher intensity, you're going to create more of a hormetic response. So that primary response might be like, geez, that hurts. You might create a bit of localized inflammation, but then that creates a cascade of physiological response where you get changes in the extracellular matrix, and then 3, 5, 7 days later, all of a sudden, the benefit of that effect is long lasting. All of a sudden, it's like, actually, my range of movement's improved. I see a reduction in pain, and it sticks. And again, like we've talked about this before, but it's similar to, say, exercise, where if you apply a low magnitude stressor, it may create a acute improvement, but it's typically going to be transient in nature. So this comes back to thinking of, well, what effects are we trying to elicit here? And, we've talked about this before, but thinking about, say, manual therapy that you apply prior to training or prior to a rehab session, you're not going to get them on the bed and try and break them. You're thinking about, what are the actual effects I'm trying to do here?
Well, and I think that's the key thing that is important. There's in my mind, at least, even from a really basic clinical perspective, there's two types of manual therapy that you're doing. One is to try and address some of these tissue changes, and basically a lot of times it's to mitigate pain responses. The second type is, as you said, this performance type of manual therapy. And they may actually be related. So someone might come to you for improving performance and saying, I'm actually being limited by pain. But there's even times where someone doesn't have pain and you actually are just assessing and looking and saying, okay, I think that we can get a little bit more range out of your hip, or a little bit more range through your ankle, or whatever it is, by applying some manual therapy to start changing this local tissue environment. Yep. And those, I think, are slightly different. I think it's really important that, part of the discussion that you always have about manual therapy and whether it's effective or not is related to pain. And for us, as you said, we've probably discussed this a million times, but there's always two parts of all the processes that you need to go through or be thinking about when you've got someone present to you. And the first one is, okay, is pain a major factor that's actually going to alter what I'm going to do to try and, to make changes that stop this injury from occurring again, and to rehabilitate them back to the level of activity that they need. And the second thing is, obviously you need to address those underlying factors that are going to either remove that pain presentation. So as you suggested before, potentially things around like the inflammatory status of the individual, and even the actual local tissue characteristics. And also, ultimately you're going to try and improve those things to the point where one of the symptoms they don't get is pain.
Yeah. And it's like, this is something that we've talked about a bit in the last couple of days of, like any situation, when someone presents with pain or an injury, you're always thinking about what's going on, but then you're always going to, well, why? Why does this person have this problem? And if pain is something that impacts your ability to apply appropriate mechanical stresses to develop the characteristics they need to mitigate injury in the future, manual therapy can be a very useful thing.
It's extremely effective, and that's where I don't know. I think I'm keep laboring the point, but I just get so annoyed with people who dispel the utilization of it. Right? It's not by any means. We spoke about this the other day. By no means is it going to be the only intervention that you apply. And
look, this is probably something you have to be critical of when you look at the literature, because I'm actually not sure. I'm not aware. I haven't really looked, but how much research has been done of, well, we use manual therapy where appropriate to regulate pain so that we can apply appropriate mechanical stresses to build up certain tissue capacities.
Yeah, you don't see that sentence being pulled out in research very often. However, if you spoke to a clinician, that's probably one of the key things that they're going to say very consistently. They're going to say, I use it when it's appropriate to modify the pain that they're experiencing so that we can do more. We can do more exercise. We can increase the level of activity they do. Maybe they can do their ADLs with more comfort, all of those kind of things.
Yeah, and this is where we need to move away from thinking of manual therapy as being the primary modality to quote-unquote cure someone. Maybe there are certain circumstances for that, but to be honest, they're going to be the exception, not the rule. And instead think about, how does manual therapy as an adjunct provide windows of improvement that allow me to then utilize other interventions, mainly exercise, to elicit the adaptations that I want.
Yeah, I really like the way that you phrase that, windows of opportunity to be able to elicit the changes that you want.
Yes.
Because I think that's how you have to see it. And whether you're using it for pain modification or you're using it for performance, we understand that manual therapy in general is going to have some sort of transient effect.
Yeah.
But it's creating, as you said, that window of opportunity. That's what it's doing.
Well, we've talked about this a bit recently where, let's say you get someone from the general population coming in with low back pain, and they've got years, if not decades, of just detraining from doing nothing. And like one of the things we've been talking about recently is, what are the expectations we have for the basic physical capacities or requirements needed to minimize
I think,
an injury?
It's probably going to annoy people, but generally most people are pathetic.
It's true. Like, the reality is we live in a society now where it's acceptable
to be pathetic physically.
I'm probably getting more controversial here, but I always find it interesting too of what people consider to be normal weight, for instance, these days. And it's interesting too, like, we work in an environment where we have some very high level athletes who are quite lean, and they're always seen as the exception of, like, oh my God, you're too skinny, or like, that's not something that's healthy. And it's like, well, actually, it's just the response from doing long-term training. We got it better? Which, when you think about it historically, like, we were always participating in high levels of physical activity throughout most of human history. It's only recently where it's become an option to essentially do nothing. And I look at it the same with regards to people that present with back pain, and you realise that they just have such little physical capacity. I think we need to be a bit more critical and look at the bigger picture of, well, what are the big rocks? What are the major reasons for why this person's getting pain? Now, even in these situations, I do think manual therapy can be a useful adjunct, particularly in those early stages where I don't deny that they might have significant pain and that limits their physical ability. But unless you're thinking more of what are the stresses I need to apply to build up their physical capacity, and the other thing of that is what's the timeline for that, then you're going to be stuck in a very vicious circle where if all you're doing is manual therapy and you're not seeing improvement, then yeah, part of the problem there is you're not applying the appropriate treatment modalities. And this is where I think a lot of the research falls short, because they do these studies of, is manual therapy effective for low back pain? And you look at the population characteristics.
Yeah, and if you're sedentary and you have very low physical capacity, correct, and you haven't exercised in years, and you're overweight, and your metabolic health is poor, and you clearly probably have signs of major inflammatory, dysfunction.
Yep.
Applying some manual therapy is not going to have long-term beneficial effects. It's not going to modify the pathology that may be present, or even the pain presentation to any significant degree.
And that's the reason why in professional sports or with elite athletes, you see manual therapy being utilized a lot, because they're ticking the major boxes already.
Yeah.
These are healthy people who participate in physical training on a regular basis, and they utilize manual therapy to support their system, both from a recovery standpoint by helping change their inflammatory status and also regulating their autonomic nervous system to be able for them to continue repeated bouts of training. And that's probably the big thing here too, is it allows you to train more. And that's essentially how we look at it. And the way that we use it in a rehab setting is it allows you to train more by regulating the amount of nociception that you experience.
Mm. Yeah, I think this has highlighted a number of areas that are just... It's almost nonsensical to me that we're having a discussion about what value it has. Right? There's an overwhelming amount of evidence to support its utilization. Is it appropriate in every setting? No. But is it appropriate, or even is it an adjunct to the majority of settings? Yes, definitely. And in some cases, it may be the primary thing that may be able to actually assist someone's recovery, because if pain is the major factor that's driving it and all of those other health features are relatively well managed, as you said, say like in an athletic population, something like manual therapy may be the thing that allows you to get over that next step to change that nociception.
And the reason for that is how it regulates your hormetic profile. Because, again, we've talked about this endlessly, but you need to apply stresses to the body in order to at least maintain certain physical capacities or physiological state, let alone trying to enhance those physical capacities.
Well, yeah, I love it. It's in some of the coursework that you put out, but you're basically saying that like there's, we live in a homeodynamic state, not a homeostatic state. And I think that that's relevant and, really important, because what it suggests is that you need to be constantly changing, not constantly staying in the same place.
Oh, absolutely.
And to me, that really highlights, and a number of people have kind of said this, but we were talking about this the other day. Effectively, if you're not getting better, you're getting worse. Right. And it's really clear in all biological systems.
Yes.
And the reason is because the outside external stresses on that system continue to be there. So if you're not elevating your capability, even with something simple like age, you're actually diminishing your ability to deal with those stresses.
There's a interesting book I read earlier this year. It's called The Comfort Crisis by Daniel Easter.
Yep.
And it's essentially talking about this topic where if you think about the relationship to chronic diseases with our current lifestyle, you can see why we have so many problems. And this actually relates to low back pain, neck pain, non-specific pain that a lot of people present with, where we can sometimes get fixated on thinking that we need to do special techniques or, very niche types of approaches. But you forget that one of the big things that drives a lot of musculoskeletal pain in the general population is just a lack of stresses and the maladaptations that occur with that.
Yeah, I think if you generally got someone healthier, right, and everyone knows, well, I think health literacy is really improved in especially a place like Australia. Everyone, if you ask them, that they know the basic tenets are, things around doing more exercise, managing your weight, eating, more nutrient-dense foods, and, avoiding some of the negative stresses or, negative vices that people have, things like smoking, alcohol, or at least, to a ridiculous amount, drugs, all those kind of things that are going to be negative.
Yeah, and then when you think too about a lot of people who present to physios, or it could be chiro, osteo, it doesn't matter, the expectations then too, because the problem that you do have is a lot of people will come with the expectation that they're going to lay on the bed and you're going to do manual therapy. And the reality is you probably can do some manual therapy and create significant improvements. Now, whether that is long-lasting is questionable, and more importantly, whether you're actually addressing the underlying major problems with their physical capacity, it's just not going to...
and that's that two-pronged approach that we spoke about before. Everyone will present, or not everyone, but most people will present with pain. Our first job, obviously, as a physical therapist is to try and help them modify that pain and that experience of pain. And then the second thing is to be able to modify the features that developed that issue in the first place.
Yeah, and then part of that is also managing expectations, because the reality is you may feel pressure to do certain things like manual therapy as the main form of treatment because that's what they want, that's what they've come to see you. But I also see that though as a failure of of you as an individual to demonstrate to that person that this is not going to provide the solution that they want. And I think part of this also too is how you manage expectations of pain when it might take some time to actually get improvements in the physical capacities they need to actually see long-term benefit. Now, this obviously varies on a patient-to-patient basis because some people are much less bothered by pain than others. And, you know, some people might come in like, oh, you know, it's a 2 or 3 out of 10, but I'm getting through everything. I'm not stopping from going to work or spending time outdoors and, you know, doing gardening or whatever it is that they may be doing. And then obviously you have people on the other end of the spectrum who basically give up doing everything and want to lay in bed because they're experiencing some back pain. You know, the other thing I think though we should talk about, we mentioned briefly before, is actually what you feel with your hands too.
Yeah, like this is obviously going on to a different topic, but it's something that we spoke about with a number of the surgeons that we've had on the podcast about like the development of skills and the development of that sensory information that you as a clinician actually get to experience and how that evolves over time. You know, I think it's always really impressive to see very experienced clinicians be able to carry out what you would consider very, very highly specialized techniques. Or even just the amount of information they seem to be able to pick up by, you know, feeling different parts of the body, whether it be a joint, whether it be, you know, like a soft tissue structure. They actually are like, you know, and I think this brings up actually another point that, you know, we've spoken about a little bit, but is how good your surface anatomy is. Can you actually identify things, and can you identify them both from the perspective of sight, but also from touch? You know, and I think that was one of the interesting things about a discussion with Pam Bokel, where she said, you know, like orientating yourself as a young surgeon sometimes can be tricky. You know, and one of the things she's like, you know, like find where the bony landmark is. That's often the key thing. If you can find the bony landmark, then you can get yourself back on track if you got a bit lost. Well,
and this is something that's worth mentioning and highlighting, because I think within our profession, physiotherapy, you're seeing manual therapy become less utilised by younger clinicians. And to be honest, you and I had this same experience when we were at uni, where I thought manual therapy was taught really poorly, and they actually didn't apply the appropriate principles for how you learn something like manual therapy, because so much of it is about hands-on experience and building up that like proprioceptive awareness. You need to do it on a regular basis. And unless you're doing it weekly, where you're getting guidance of what you're feeling and how you actually locate through surface anatomy, you don't actually develop the art form of manual therapy. And
that's why I think for younger therapists, it's really important that, particularly even while they're at university, to do things like, you know, sports training.
Yeah.
You know, it's really, really valuable for them, because not only do they start to get exposed to more of the diagnostic kind of skills and the ability to kind of identify, you know, different features that are coming across in real time, and that's a skill that you have to be able to pick up as a clinician. But they actually get to feel a lot of bodies. You're doing a lot of general manual therapy. You know, people always get upset. It's like you're rubbing calves. You know, if you're working at a footy team consistently, you know, everyone, oh, my calves are tight. Can you get into them? Or I'm cramping, or whatever it is. But actually starting to get a lot of hands-on, and the amount of different people that you actually get to feel their tissue, and knowing what that feels like, and saying, okay, this person's got low tone, this person's got higher tone. You know, I'm feeling through this ankle joint, this joint's loose, this one's really stiff, this one doesn't have any, you know, joint range. That starts to give you, as you said, that appreciation of that nuanced feel.
Yeah, and the variability that you see and how that relates to someone's movement ability or performance ability. Because, you know, something that we've talked about is the tissue you feel with, say, an elite sprinter or a long jumper is very different to, say, a football player. And there's a reason for that. And like in particular, feeling for the development of the connective tissue system, because you can start to feel that the density of the collagen that's been laid down around the muscles and the compartments, and also the density of which their muscle fibers are laid down as well, which, again, when you think about it, makes a lot of sense, because for an elite sprinter, they want to have maximizing cross-sectional area of contractile units without, you know, becoming a bodybuilder where it compromises their ability to move quickly because they become too heavy. And then we can even start to think about other things. Like, I always find it interesting when you get someone coming in who may not necessarily look like they're overweight, but you actually feel their tissue and you feel there's a lot of adiposity within their trunks, for instance. And again, that gives you a really good indication when you think about their anthropometrics of, say, fat mass to fat-free mass, of going, okay.
Yeah, that's the biggest thing. And it's interesting, like even as a coach, who is a therapist at the same time, one of the things that I'm consistently looking for and trying to feel over time is say the tissue density going up. Is that feeling of space within the tissue, how much firmness it has to it, that, as I said, that intra compartmental kind of almost adiposity disappears, and their tissue does not feel soft. Their tissue has like a very nice springy firmness to it. And that to me says that density, particularly of the muscle and the connective tissue, is actually increasing over time.
Well, I imagine too, the other thing that you would find with having your hands on the same athletes on a regular basis is seeing the relative tonicity too, because that's going to give you an indication of what their overall system state is like, because you're going to get an indication of this person's typically low tone or they might be high tone. How is that changing over time? Because all of a sudden, you start to feel high tone in someone who's quite generally low tone. That gives you information of this person's saying that they're feeling a bit tired. Maybe they're starting to get an imbalance within their autonomic nervous system because they're overtraining or whatever it may be.
You mentioned autonomic nervous system there, and I think that this is an area that there is more and more emerging evidence that things like manual therapy, in particular specific types of manual therapy, may actually be able to upregulate or downregulate autonomic nervous system function.
Yeah.
So do we want to kind of explore that a little bit? Because
Yeah.
I know for me, I'll use certain techniques that are probably more aggressive if I want to maintain sympathetic tone.
And would you want to elaborate on that, when you use that and why?
Yeah, so for instance, if it's like, say if we're at a competition and someone's feeling a little bit stiff in their hips or their back, I'm not going to do very gentle, well, depends on the person and how amped up they are, but generally I'm going to try and do much faster moving, much firmer, and much shorter duration activity in terms of the manual therapy that I do or the intervention that I do, because I'm trying to maintain that level of sympathetic tone that they've got. I don't want to put them to sleep before they actually go and do their competition. Whereas if they are post-competition, it's the complete opposite. I'm working a lot slower. I'm probably not going necessarily as deep, or if I am, I'm taking a long time to get to that level of depth of pressure that I'm applying. You're probably going to actually the type of techniques that you do will be a lot more calming and relaxing. So you're actually trying to almost like reduce that sympathetic tone and push them towards that more parasympathetic kind of behavior. You're trying to calm their system down. And if you get those wrong, you can put someone to sleep before a race or amp them up, and then they're like, I felt worse after that treatment. I'm feeling almost tired now, and not tired, but almost like I'm too amped up. And I actually, like, say for instance, you do it just before they're about to go to sleep. It's like you want to put them to sleep because that's restorative, rather than waking them up and then they're feeling really amped.
Well, and that highlights the importance of timing in this situation. And this is, I think, where it's interesting to think about different types of manual therapy like dry needling, because I know we utilize that a lot. And for those who use it, again, you can elicit different response depending on how aggressive you are, the actual depth of it. But just one of the great things that it's good at doing is regulating their autonomic nervous system, particularly if you want to really elicit a large parasympathetic output.
If you're aware of it, but what specifically... I have a very general overview of what that's doing from that physiological standpoint. What actually is that doing? Do you know what the mechanism behind the actual application of needle into tissue does from an autonomic nervous system point of view? Yeah,
well, like I know there's certainly has a big influence on regulation of pain centers within the central nervous system and the secretion of things like endorphins as well. Now, I mean, you get that with any manual therapy. It seems that you get a larger response from dry needling. To be honest, I actually haven't looked at it in a lot of detail, so I'm perhaps not the expert or the person to talk to about it. But
maybe we'll have to find someone who...
Yeah, that's true. Yeah, but it's something that's very clear. And I even know from myself, but you even see it with other patients you do it with when they get up and it looks like they're just about ready to go to bed.
But as you said, I think that very much varies depending on how you do it. I've even heard of, there was a physio that was part of our course who explained to me he was working heavily on the tennis tour. And he was saying like he would take needles with him, and they often actually would maybe even use them, like they'd be in the airport and they'd be like quickly doing stuff for people as they're sort of in transit. But he was saying, you know, when they did that, it was quick, short, sharp, elicit some of those sort of twitch responses that you would typically get. You're not going to leave the needles in for half an hour, right? Whereas if you're trying to put someone into a more parasympathetic state, you know, you'll put the needles in, you're not going to touch them a hell of a lot. You're not going to be trying to elicit those twitch responses. You're going to let that calm down.
Yeah, definitely. Again, what this highlights though to me is you're using manual therapy to regulate the state of the system, because one element to realizing the effects of training is making sure that you get adequate recovery. It's probably one of the big issues that a lot of athletes experience is because they're always doing really high intensity training, it's really getting them amped up. And like that's something that you see with particularly certain profiles or personalities is they actually don't know how to shut down.
Yes.
And these are the people who might have issues with sleeping, or they're the kind of people who are always thinking about or their next training session they can't switch off. And
I think you would say that these are people who generally their sympathetic tone is high.
Yes, yeah. And this is where it's really useful because they're the kind of people who do need to switch off, and you can actually utilize manual therapy to your advantage. But it's interesting, this is something that, you know, we've talked about. You actually got to be very careful with the timing of certain modalities. Like, for instance, we've noticed that with, say, stretching, with certain types of profiles where, because stretching, again, creates a large regulation on your autonomic nervous system by particularly upregulating the parasympathetic nervous system.
Well, especially if it's sustained stretching, you know, if you're doing stretching for an hour or something like that.
Yeah, and part of that is because of the fact that it regulates things like noradrenaline within the central nervous system, and that has a big impact on your ability to recruit motor units and have things like persistent inward currents that regulate the ability to maintain, say, high motor unit frequency and things like that. So, you know, this is where I think we need to be thinking at this level of where manual therapy is actually applied.
Yeah, that's the key thing, is the level of discussion about manual therapy is so low resolution that we're getting a very poor message about why it's effective. It's not, to be honest, and we've spoken about this, it's the wrong question to be asking of whether it's effective. The question we should be asking is, why is it effective, and in which situations should we apply specific interventions?
And it's the same reason why we're critical of things like, is this a good exercise for hamstring strains? And you go, well, like maybe, but again, you can't be thinking at that level. We need to be thinking of
that's too low a level of thinking.
Totally. What are the deficits we identify? And then what are the appropriate stresses I need to apply to that individual based on their current physical capacity, based on their adaptability, based on the maturation of the system that I know is going to elicit a positive adaptation.
Yeah, I think that's probably an overriding message for anyone who's listening about this when they're talking about manual therapy. If you're thinking at the level of whether it's even useful, you're missing the point.
It'd be the same thing as saying if someone had strained their hamstring before who has never done resistance training, would you use manual therapy potentially as an adjunct to help regulate pain? Is that going to be the main form of intervention you're going to use to get that person to have a good outcome? Probably not, particularly in that situation where if they've done no resistance training and they've got low maturation, they need to focus on building some basic tissue capacity. And that's like a really low level way of looking at it. But unless we start to transition how we think about applying different interventions based on what you think's going on, then I think that's when you have limitations of understanding when it's useful to use certain interventions and when it's not. And like that's obviously something that you and I really focus on is first principles. You know, really focus on understanding what neurophysiological adaptation is occurring from that stimulus and why you think it's relevant to that individual.
All right, Jack, I think that's probably covered on most of the things we wanted to talk about with manual therapy. I'm sure this topic will come up again at other points, but thank you for your time today.
Thanks, John.
Thank you for listening. If this is something that you've enjoyed, please like, subscribe, and share this podcast with fellow listeners.